Clinical presentation of a patient having cystic fibrosis. Clinical presentation. A girl aged 18 years presented to a medical department of a hospital with several years history of a chronically productive cough with associative shortness of breath and wheezing. She also reported of lethargy, night sweats and weight loss. She had been screened for tuberculosis with a negative Mantox test 5 years previously. Initially, the patient had been managed by her GP who had referred her on to secondary care with suspected asthma. Owing to her ongoing symptoms, a chest X-ray was performed which revealed bilateral hilar lymphadenopathy, resulting in a referral to the hospital. Past medical history. Born in Canada in 2005 at 38 weeks of gestation, she was the fourth infant of non-consanguineous parents. She had been fully immunized. Her parents report she developed a cough soon after birth which persisted for most of her life. She was first acutely unwell with a productive cough and weight loss at the age of 8 years while on holidays with family. On return to home, she was hospitalized and improved following a course of intravenous antibiotics. It was 3 years after this episode that she was started on asthma treatment following the development of a chronic cough. Family history. She only had positive family history of atopy. And what is atopy? Atopy refers to the genetic tendency to develop allergic diseases such as allergic rhinitis, asthma and atopic dermatitis, that is eczema. And you don't have to write the definition of atopy in your document. It's just for your own knowledge. Examination. On initial examination, her chest was not clear on auscultation and she had several small submandibular lymph nodes. Her height and weight were not according to her age. Repeat TB investigations including Mantox, T-spot and sputum AFP were negative. Her sputum culture grew Staphylococcus aureus and she was treated for a lower respiratory tract infection. She was symptomatic with a chronically productive cough and poor appetite. Further questioning revealed abdominal pain and steatorrhea. Examination at this point revealed finger clubbing, prompting further investigations into an underlying chronic respiratory condition. Investigation. Number 1. High resolution CT chest showed widespread bronchiectasis with evidence of mucus plugging. Number 2. Sweat test revealed a high chloride level of 81 with more than 60, reflecting a likely diagnosis of cystic fibrosis. Number 3. Subsequent genetic testing confirmed cystic fibrosis with a C1040G2C P mutation and exon 14B deletion present. Number 4. Lung functional tests at the time of diagnosis revealed an FVC, that is forced vital capacity, of 73% predicted and an FEV1, forced expiratory volume in 1 second, of 54% predicted. There was also evidence of pancreatic insufficiency as her fecal elastase level was less than 15 microgram. Diagnosis. From the laboratory test results, she was diagnosed with cystic fibrosis. Management plan. Following the above investigations, the patient was started on regular pancreatic enzyme replacement therapy, fat-soluble vitamins, nebulized DNAs, and prophylactic flucloxacillin. She was also seen in the multidisciplinary cystic fibrotic clinic, receiving dietetic and physiotherapy input. She had her first isolation of Pseudomonas several months after diagnosis, which led to a 2-week admission for intravenous anti-pseudomonal antibiotics. Following this, she was started on regular nebulized cholestyramine sodium. Prognosis: there is no cure for cystic fibrosis, but treatment can ease symptoms, reduce complications, and improve quality of life. Close monitoring and early aggressive intervention is recommended to slow the progression of cystic fibrosis, which can lead to a longer life. There are two types of goals in terms of management. Number one is short term goals, and number two are long term goals. Short term goals: to ease patient symptoms, that is, cough, shortness of breath, night sweats, weight loss, poor appetite, lethargy, etc., conservatively by medications and physiotherapy. Number two, long term goals. There is no permanent treatment for cystic fibrosis, but to increase the quantity and quality of life, lung transplant can be an option, although it will not change the fact that patients' rest of the body will continue to have cystic fibrosis. Outcome and follow-up. After the initiation of treatment, the patient's long-standing symptoms, including cough and loss of appetite, improved. Her weight and height increased to between the 9th and 25th centile. In addition, her lung volume improved with an forced vital capacity of 89% predicted and FEV1 of 90% predicted following her admission for intravenous anti-pseudomonal antibiotics. She remains under regular review at Cystic Fibrosis Clinic. And here are the references. Thank you.